Hi everyone, welcome to our presentation on obsessive-compulsive disorder. Before we begin, I just wanted to give you a brief outline of what we'll be covering in this presentation. So first we'll start with the diagnostic criteria for OCD, then we'll talk about the epidemiology, the etiology, then we'll move into the developmental course, the prognosis, assessment, and then finish up with the treatment of OCD. So to begin with, we're going to talk about the DSM-5 diagnostic criteria. So OCD can be found in the obsessive-compulsive and related disorder section of the DSM-5. So other disorders that are listed in this section, of course, it'll start with obsessive-compulsive disorder, and then it moves into body dysmorphic disorder, hoarding disorder, substance or medication-induced obsessive-compulsive and related disorder, obsessive-compulsive and related disorder due to another medical condition, unspecified obsessive-compulsive and related disorder. So those are the other disorders listed in that section as well. And the DSM-5, the diagnostic code for OCD, is going to be 300.3. It's important to note that the DSM-5 does also include the ICD-10 diagnostic codes, but for the DSM-5 specifically, the code is going to be 300.3, and we'll talk about the ICD-10 code in a moment. So in the DSM-5, the following diagnostic criteria for OCD are included. Starts with the presence of obsessions, compulsions, or both. And the DSM describes obsessions as either one, recurrent and persistent thoughts, urges, or impulses that are experienced at some time during that disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. And two, the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. And then compulsions are defined by the following 1 and 2 points. So number 1, repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. Or 2, the behaviors of mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or they're clearly excessive. And then the next diagnostic criteria is that the obsession or compulsions are time-consuming or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The next criteria is that obsessive-compulsive symptoms are not attributable to the physiological effects of a substance or another medical condition. So we kind of talked about some of the other conditions that would be listed in this section of the DSM, so some of those might be more appropriate. And then finally, the last criteria is that the disturbance is not better explained by the symptoms of another mental disorder. The DSM also includes a few specifiers, so one is with good or fair insight. So this would be that the individual recognizes that obsessive-compulsive disorder beliefs are definitely or probably not true, or that they may or may not be true. With poor insight is that the individual thinks that the obsessive-compulsive disorder beliefs are probably true. With absent insight or delusional beliefs, the individual is completely convinced that the obsessive-compulsive disorder beliefs are true. And then there's another specifier if the disorder is tic-related, so this would be indicating that the individual has a current or past history of a tic disorder. So now we're going to move into the ICD-10 diagnostic criteria. So in the ICD-10, the diagnostic code for OCD is going to be F42. There are also specifiers that have different decimals, so we'll talk about that in a minute. But according to the ICD-10 classification of mental and behavioral disorders, there are several diagnostic criteria for OCD, and these will be quite similar to the ones that we discussed from the DSM-5. But the first criteria here is that either obsessions or compulsions or both are present on most days for a period of at least 2 weeks. The next criteria is that obsessions, so these are thoughts, ideas, or images, and compulsions, the acts, share the following features, all of which must be present. So 1, they are acknowledged as originating in the mind of the patient and are not imposed by outside persons or influences. 2, they are repetitive and unpleasant and at least one obsession or compulsion must be present that is acknowledged as excessive or unreasonable. 3, the subject tries to resist them, but if very long-standing, resistance to some obsessions or compulsions may be minimal, and at least one obsession or compulsion must be present which is unsuccessfully resisted. And then finally, carrying out the obsessive thought or compulsive act is not in itself pleasurable. So this should be distinguished from the temporary relief of tension or anxiety. So other than releasing some of the anxiety by the thought, the compulsive act, or again, the more thoughts are not pleasurable to the person experiencing them. And then the next criteria is that the obsessions or compulsions cause distress or interfere with the subject's social or individual functioning, usually by wasting time. And then finally, most commonly used exclusion criteria. One is not due to other mental disorders such as schizophrenia and related disorders or mood affective disorders. So we're going to talk about the diagnosis specifiers with the following codes. So we have 4 additional decimals other than 42.0, which is predominantly obsessional thoughts or ruminations. 42.1 is predominantly compulsive acts, obsessional rituals. 42.2 is mixed obsessional thoughts and acts. 42.8 is other obsessive compulsive disorders, and 42.9 is obsessive compulsive disorder unspecified. So now we're going to talk about the epidemiology, which will include both the prevalence and the incidence of a disorder. So the prevalence is the number of people in the total population who have a certain disorder. In our textbook, it talks about the lifetime prevalence of OCD ranging from about 1.6% to 2.3%. And in a 12-month window, the prevalence of OCD in the United States is 1%. Internationally, that number is similar, with a 12-month prevalence being 1.1% to 1.8%. So continuing on, the incidence is the frequency, rate, or number of newly diagnosed cases in a given year. And because different studies for OCD may vary in their methodology, it can be difficult to compare those findings and to draw conclusions about the changes in the incidence over time. But we did look at one particular study by Rentala and colleagues that found in their sample that the incidence by age 15 had increased. So for males, it increased from 12.4 to 23.7 per 10,000 live births, and for females, it increased from 8.5 to 28 per 10,000 live births. And that study also found the cumulative incidence for their sample population that they were working with was 0.4% by age 23. They did find overall an increase in incidence, which they attributed either one, that this population was particularly seeking mental health professionals, so perhaps just more people were seeking help than before, or two, the disorder is really increasing among the population. So they did state that there may be, maybe one or the other. So now we're going to move on to the etiology, which is what causes or contributes to a disorder. So for psychological disorders, we've talked about quite a bit that this will include biological, psychological, and social dimensions. So for OCD to develop in particular, there has to be a generalized biological and psychological vulnerability already present. And then these vulnerabilities are compounded when stressful life events are introduced. So one hypothesis that's discussed in our textbook is that people who develop OCD are learning from early experiences, 1, that certain thoughts are dangerous, 2, that those unacceptable thoughts might actually happen, and 3, if they do happen, then the person thinking those thoughts would be the responsible party. They'd be the reason or the cause. So one possibility then is that those early experiences could lead then to a more specific psychological vulnerability to develop into OCD. And then we also included this figure which models the causes of OCD. This is recreated from page 172 of our textbook, which has a very nice graphic of it, but we did recreate it on the following slide. So there you can see at the top we have the generalized psychological vulnerability and the generalized biological vulnerability. Those are being compounded at that stress due to life events. And at that point, the intrusive thoughts, images, or impulses would be introduced, which would lead to then more specific psychological vulnerabilities. So then that branches out to both anxious apprehension and false alarms. Once those false alarms are reinforced to become learned alarms, it leads to more anxious apprehension, which then takes us down to cognitive or behavioral rituals to suppress the thoughts. So that would be where your obsessions and compulsions are coming into play. And then finally, that leads into obsessive compulsive disorder. So that takes us on to the developmental course of OCD. The average age of onset varies between men and women, and males would have the earlier age of onset. So for males, they typically experience childhood onset between the ages of 6 and 15 years old. In the United States, the mean age of onset is 19.5, and 25% of cases begin by age 14. Onset is rare to occur after the age of 35, so it is more of that childhood to early adolescence. That would be the typical onset. And although OCD typically develops more gradually, there could be psychosocial stressors like changes in living situation, relationship problems, or work problems that can cause a more sudden onset than is usually seen. So moving on with the developmental course here, this disorder is marked by recurrent unwanted or distressing thoughts, the obsessions, or repetitive irresistible behaviors, the compulsions. And so a majority of those diagnosed with OCD will have both obsessions and compulsions. So we talked a little bit about insight. So insight is how much or to what degree they acknowledge their obsessions and compulsions or their beliefs as senseless or excessive at a given point in the illness. So we talked about the varying levels of insight that you would specify when diagnosing OCD. Compulsions usually reduce anxiety. The ICD-10 diagnostic criteria alludes to that. Other than the pleasure in reducing the anxiety, these compulsions and these obsessions, they're not pleasurable to the person to experience. And again, these symptoms will produce subjective distress. They're time consuming. Typically more than an hour per day would be considered excessive, or they interfere with functioning, like we talked about, socially, relationally, work, different dimensions that would be impaired. So some of the concerns that are related to the obsessions could be contamination, aggression, like we saw in the last slide with the knife or the wanting to shout something obscene. Could be safety, harm, concerns, concerns that are overtly sexual in nature, religion, somatic fears, and also there's the need for symmetry or exactness that can be seen. So some examples would include doubting that the door is locked or the stove is turned off, images of hurting oneself or someone else, or fear of being contaminated by touching objects that others have touched or that appear dirty. So now we're going to move into the compulsions. These would be repetitive behaviors that the person feels driven to perform that either, one, they're in response to an obsession, or two, they are following a very rigid set of rules. So these repetitive behaviors or mental acts are meant to prevent or reduce anxiety that are related to the obsessions, and these acts are excessive and or senseless. So some of the behaviors that are seen with the compulsions would be cleaning or washing, checking, arranging and ordering, counting, repeating, hoarding, and collecting. And some specific examples would include hand washing until the skin becomes raw. So the fear of being contaminated leads to washing the hands over and over and over until the skin is rubbed raw. counting in certain patterns, silently repeating a prayer word or phrase. So again, this would be excessive. This wouldn't be just uttering up your favorite prayer. This would be something above and beyond that. Or checking repeatedly to make sure that the stove is off or the door is locked. So again, that obsessive thought of the stove is left on, the door is unlocked. Then we have this paired, the checking behavior that's paired with that to check if the stove is off, to check if the door is locked. And again, this would be, more than just checking the door is locked before you go to bed. This would be a constant need to check to reduce anxiety about that. So now we're going to move into the prognosis of the disorder. So as we discussed briefly before, OCD is the result of a combination of things, including neurobiological, genetic, behavioral, cognitive, and environmental factors that trigger the disorder in a specific individual at a point in time, at any given point in time. So it's also believed that individuals suffering from OCD have faulty or dysfunctional beliefs that are either misinterpretations of intrusive thoughts that lead to the creation of obsessions and compulsions. And if left untreated, OCD typically follows a chronic course with periods of waxing and waning symptoms. So for the most part, this is more of an ongoing disorder, and remission rates in untreated adults especially are very low. So treatment is very important for an improved prognosis. Only 20% of adults who are evaluated 40 years later showed signs of remission. And the onset of OCD, as we discussed before, typically happens during childhood or adolescence, and that may lead to a lifetime of the disorder, but up to 40% of those who do have that earlier onset may see remission in early adulthood. So again, here, treatment is going to be a really important factor in determining the prognosis. And so moving towards the assessment side of things, the ability to identify the symptoms of OCD can be the first step in getting effective treatment and relief. Since OCD can be more of an early onset, in children it is more likely that you would notice the compulsive behaviors before the obsessive thoughts, just because those are easily observable, or the thoughts, the child may not be able to express those. So it may be more likely that the compulsions are noticed first. But when evaluating for OCD, mental health professionals use a variety of different methods. So this could include diagnostic interviews, self-report measures, or clinician-administered inventories. So diagnostic interviews are going to help facilitate diagnostic decisions. They utilize specific questions to assess symptoms according to the DSM-5 criteria that we talked about before. Self-reported measures, here the advantage is that they are quick and they can be independently done, and they can also help guard against underreporting or overreporting of symptoms to some degree, and that they wouldn't feel the need to hide some of those symptoms or to over-exaggerate those symptoms in front of a clinician. It would be more an independent thing, of course. With any measures like this, there is some chance of dishonesty, but that, of course, is something that the clinician would be looking for as well. And then the clinician-administered inventories, this allows for a trained clinician to make an informed rating of OCD, regarding the impairment and distress in comparison to cases they have seen before. So one of the more commonly used assessments is the Yale-Brown Obsessive-Compulsive Scale. So using this inventory, the clinician would ask questions about how much time the obsession and compulsion, or the multiple, may take, and how much distress those obsessions and compulsions may cause. After these questions are answered, the clinician is going to score the items and then take into account also any behaviors that they observed while the inventory was being administered. So just to highlight briefly what that particular inventory looks like, here's the different scores. So 0 to 7 would be subclinical level of OCD, 8 to 15 would be mild, 16 to 23 is moderate, 24 to 31 is severe, and 32 to 40 is extreme. So it's a 0 to 40 scale. So for treatment, unfortunately, there isn't a cure for OCD, but some of the most effective treatments for OCD would include cognitive behavioral therapy as well as medication. So, first, we're going to talk about CBT. So, this is an attempt to change the thinking and behavior using a variety of techniques. So, one would be exposure and response prevention, ERP, and then just cognitive therapy as well. So, for ERP, during those sessions, the therapist is going to gradually expose the person to a situation that triggers the obsessive or compulsive um, symptoms. So, if it's contamination, it would be exposing them to something related to the contamination. If it's things of that nature, is what they'd be focusing on. In cognitive therapy, those sessions are going to help the individual identify and modify patterns of thought that cause anxiety, distress, or negative behavior. So, this process helps the person understand that their brain is sending error messages, and it's also going to help them recognize the errors of those messages and to confront the obsessions by responding to them in new ways. So, this would also be a part of the goal of ERP as well. Um, with both of these types of therapy would be to help them respond in more appropriate ways, and to kind of create new messages. So, as we briefly mentioned before, along with cognitive behavioral therapy, medications are also used to help lower the anxiety that's related with obsessions and to reduce the urge to perform compulsions. So, the most effective medications are SSRIs, and 60% of patients with OCD experience benefits when using SSRIs. And again, typically medication and therapy would be used in conjunction. And though medication is used in treatment, it sometimes is more on a temporary basis until that person is able to cope with the symptoms of the disorder with the help of therapy. So these may be paired together, or therapy may be a standalone treatment. Um, but that really concludes what we have to share with you about OCD. So we hope this has been informative for you. As you can see, we do have a few references, so feel free to take a look through these. And again, we have a few more references here. But thank you so much for taking the time to view our presentation and to comment on your thoughts. We hope that this was a beneficial experience for you. So we're going to talk more specifically about the OCD obsessions. So again, these are going to be recurrent and disturbing thoughts. They could be also images that are intrusive, or excessive worries about real life events. So you can see here the difference. We have intrusive thoughts and that little thought bubble, the urge to shout out something obscene in public. We have an intrusive image of a knife, leading then to the thought about the thought about the thought or the image. So I'm not in control of myself, I'm in danger, and then that produces an emotion of anxiety or fear.